Look at this question. If you think the answer is levator palpebrae superioris, do not skip this reel. This is PYT2 of our final leap series. If you haven't checked our previous reel, go check it out after this reel. Okay, as always, concept before answer. Okay, this was a case of Horner's syndrome, which is oculosympathetic palsy. The sympathetic supply to the eye starts from the hypothalamus, where the fibers descend down from the hypothalamus to the ciliospinal center, which is present from C8 to T2. From there, the second order neurons, that is the preganglionic neurons, continue to the superior cervical sympathetic ganglion. And from there, the third order neuron or the postganglionic fibers reach the eye. Innervation to the dilator pupillae muscle is given through the long ciliary nerves. Some fibers reach the smooth muscle of eyelid, that is the Mueller's muscles, whereas some fibers reach the sweat glands in the face. And these are various causes of Horner syndrome due to lesion at various sites in the pathway. For clinical features, remember the mnemonic high maple. H for heterochromia iridis, that is ipsilateral hypochromia. This is seen only in congenital Horner syndrome. I for inferior eyelid elevation due to paralysis of the tarsal muscle, which is analogous to the Mueller's muscle of the upper eyelid. Then MAP stands for meiosis, anhydrosis and ptosis, which form the classical triad of Horner syndrome. Meiosis is due to paralysis of dilator pupillae muscle, anhydrosis is ipsilateral loss of sweating, and ptosis is drooping of upper eyelid of the ipsilateral eye due to paralysis of the Mueller's muscle. Then L for loss of ciliospinal reflex and E for relative anophthalmos, which is not actually true anophthalmos, but it is apparently seen due to ptosis and inferior eyelid elevation. These are the diagnostic tests for Horner syndrome. First, we have Cockayne test. Usually, sympathetic nerves release norepinephrine at the iris dilator muscle. Cockayne blocks the reuptake of norepinephrine and that accumulates in the synaptic cleft. So, in normal eye, it causes pupillary dilatation. Whereas, in Horner syndrome affected eye, there is no release of norepinephrine due to paralysis of the sympathetic nerves. So, there is no dilatation of the eye. And in 1% apraclonidine test, apraclonidine is mainly an alpha-2 agonist with weak alpha-1 activity. In normal eye, there is weak alpha-1 effect, so there is little or no pupillary dilatation. But in Horner's eye, because sympathetic supply is lost, denervation hypersensitivity of alpha-1 receptors develops, which causes pupillary dilatation in the Horner syndrome affected eye. 1% amphetamine test for localization of the lesion. If it causes dilatation of the pupil, there is central Horner syndrome or preganglionic Horner syndrome. If there is no dilatation of the pupil, then it is postganglionic Horner syndrome. So back to our question, the answer is Mueller's muscle. Levator palpebrae superioris causes complete ptosis due to paralysis of the oculomotor nerve. But whereas in Horner syndrome, we see partial ptosis due to paralysis of the Mueller's muscle.